strain of the rotator cuff. The main things that the rotator cuff does is it does initial abduction of the arm, or it rotates the humerus, right? That's why it's called the rotator cuff. It consists of 4 muscles: the supraspinatus, which does the initial abduction; the infraspinatus, which does external rotation, boom; Teres minor, that does external rotation; and subscapularis, that does internal rotation. The most common of these muscles to get inflamed, well, take a guess as to which one you think it is. I would say the one that I see by far and away the most in clinic is definitely supraspinatus. Why do you think that is? Because the supraspinatus, it starts at the top of the scapula and it goes underneath the acromion and above the the head of the humerus, and inserts out here. So it's a flat muscle that goes through a narrow space. And in that narrow space, it can rub. We have the subdeltoid and subacromial bursa in there to protect it. And we'll talk about that in a little bit. To protect it from rubbing on the bones, but it's still going through a narrow space. And when things like ligaments and tendons and muscles go through narrow spaces, they get it inflamed. It just, it's too easy for the space to get narrowed, and then you get inflammation, and then things go wrong. The pain, the main symptoms of this are going to be pain in the shoulder and restricted movement of the humerus. Usually it's going to be a dull pain. It can be sharp, especially if there's a history of an acute injury. Usually it has an insidious onset. So it's one of those things, it's just going to kind of creep up on you. And it can also lead to frozen shoulder. We have a whole bunch of stuff that can lead to frozen shoulder, but this is one of the main ones. Okay, so physical exams for the rotator cuff muscles. These are kind of difficult to remember sometimes, but we're going to start off with supraspinatus. Now, supraspinatus, it does initial abduction of the humerus. So it's the muscle that very first starts movement as you're going this way. So we're going to do resisted range of motion initial abduction. We're going to bring it out about 5 degrees. Now push up against my hand here as hard as you can. Does that cause pain?
No.
All right. That's a negative test. That one's not super good, It's not my favorite. I prefer empty can test. So we're going to bring the arm up to 90 degrees. We're going to abduct to 90 degrees. We're going to flex, bring it forward 45 degrees. Internally rotate it so the thumb is facing down. So it's like you're pouring out a can of beer or Coke or whatever. Now I'm going to stabilize here. Now I'm going to push down. You push up as hard as you can, okay? Ready? 1, 2, 3, go. Was that as hard as you could hold?
It was.
It was, okay. So, weakness or pain indicates strain of the supraspinatus. So I think you have a strain of the supraspinatus.
This is my chronic side.
And that's the side that you messed up. Okay, so normal healthy person can hold it up pretty well. Let's do the other side just to see if it's different. So abduct to 90 degrees, flex to 45, internally rotate, stabilize. I'm going to push down. You push up as hard as you can, okay? 1, 2, 3, go. And that hard side is a lot stronger. Now, one of the keys, though, is that you really have to try to move the arm in this case because you're testing for weakness. If you don't try to move the arm, you're not testing for weakness, so you have to do that. These other ones, you don't try to move the arm, you just have them push up against you. So next we're going to do, and this is out of order of the sits. So this is cyst. So we're going to bring the arm up to 90 degrees. Now, stabilizing here, put the hand on the back of the wrist. I'm going to have you push up against my fingers here, okay? As hard as you can. Does that cause any pain?
No.
All right. So this is the test for infraspinatus. It's resisted range of motion testing. All of these tests are resisted range of motion tests. So this is RROM, resisted range of motion, external rotation at 90 degrees. And the way you can remember that this is for the eye is infraspinatus is this is like right in an eye, right? Now we're going to bring the hand up to here. I'm going to put my fingers in front of his wrist. Don't move this, just move here, push against my hand here. Now this is the test for subscapularis. And the way you can remember this is the sub goes down. Next we're going to test for Teres minor. So this is 0 degrees and external rotation. So we have the patient stabilize here, push against my fingers here, just here. Does that cause any pain?
No.
This is crossing a T, so it's Teres minor, T. And those are the resisted range of motion tests for the rotator cuff. So we're going to do each rotator cuff muscle a little differently. For the infraspinatus, we're going to go right across that that infraspinous fossa. So here's the spine, here's the scapula. This is a big sheet of muscle, right? So we're going to start on the medial side. And we're going to try and hit as much fibers as we can going across. Now we don't have to worry about a pneumothorax at all because we have that whole scapula between us and the rib cage, right? So as long as you're on the scapula, you're fine. You're golden. Now, for this one, I would definitely do SI3 as a distal channel. Why? Or distal point. I mean, this isn't connected to the spine at all. So why am I doing SI channel? Because it's the SI channel. I'd also do large intestine 4 because there is that musculotendinous channel that branches off and comes across the scapula and inserts onto the spine. So that's the needling for the, specifically for the infraspinatus. Now, whenever I'm doing anything with the rotator cuff, I do 2 very specific points for anything with the rotator cuff. And those are going to be through the bicipital groove. I don't know if you can get the camera lower down or not.
Sure.
But right here is the bicipital groove. I'm going to do 2 needles going through. And you can do this with them lying face down, as you can see. Now the reason that I'm going through the bicipital groove is because all of the muscles of the rotator cuff insert either on the greater or lesser tubercle of the humerus. And the greater and lesser tubercle of the humerus are the borders of the bicipital groove. So this is an excellent, excellent adjacent point to use.
That's strong.
So I'm going to demonstrate the supraspinatus next. Supra above, spinatus spine. And this one, got a couple different ways we're going to do this one. The first thing we're going to do, we're going to go here to SI12. Go just a little bit lateral to it. We're going to go back through. Remember, this is a tube-like muscle. This is a really good example of a tube-like muscle where you're going through to fill as much of that tube as you can. As long as you're staying on the scapula, you can go down and actually touch that scapula pretty well. The next one we're going to do, and I'm going to have to move around for this, so I'm going to block the camera shot, but I'll try not to too much. So we're going to find LI16. We're going to go just posterior and lateral to it. So we're going along that muscle. Now if I went in this way, that would be a pneumothorax territory. But because I'm going out and sliding underneath the acromion. I don't need to worry about that. And I've actually been able to get it all the way through that space between the acromion and the head of the humerus. But in this case, I don't think I am. But if you think about it, there's enough space for that ligament to go through. So if there's enough space for a ligament to go through, and we can go through ligaments, we can get a needle through. So, infraspinatus, supraspinatus, Teres minor. Teres minor is one of those ones where we're not really going to be able to get the whole sheet and edge and stuff. We're just going to go right up to SI 10. Go straight in towards the floor. Trying to scrape right by the edge of the scapula. Boom. Ooh, that's sucking in. Now, one last one to do. I'm going to take these needles out so I can demonstrate that. It's going to be subscapularis, and we're going to do that both face up and face down. You okay with that?
Uh-huh.
Are you asleep again?
Nope.
We just had lunch, so it's a good time to nap. Now, usually I would do these with 3-inch needles, but we don't have any, and I'm okay with just doing shorter needles for today. So, subscapularis means underneath the scapula, which we need to get underneath the scapula. So we're going to move the arm up like this. Boom. You see how that wings that out really nicely. But going underneath the scapula means that we run the risk of a pneumothorax. So to minimize that, we're going to find an actual rib. Here's a rib. Here's the space above. Here's the space below. You put your fingers in those spaces, so the rib is between your fingers, and then you press up underneath the scapula, slide right underneath that scapula. Oop, that's as far as that wants to go. That's bending that needle. All right, boom. And then you can move the arm down. Notice how the position of the needle changes. You don't have to worry about it changing underneath the scapula though. Put the arm back in position. Take the needle out. And I'm going to have you flip over. Nice and slow and easy. You got a big pile of trash here, but nothing to worry about. Yeah, I got that out from under you. So, needling the heart one from the front. You're going to bring the arm up like this. You're going to have to put your fingers up into the axilla, the armpit. You don't really have a choice here. So you find that heart one. I'm going to push this direction and then posteriorly. So superior, medial, and then posterior. And I can feel that muscle. As I can go back, I can feel the edge of the scapula. I can go back and I can get on that muscle, and you can see it's making them flinch. So bring the arm down like this to relax that muscle. And then going superior, medial, and then posterior. You can actually feel the scapula and the muscle. I'm going to hold that position and go in with the needle. When I was in master's studies back in 1998, my roommate, hi Sandy, told about the time that they first got this done, and the first time they got it done, they had an emotional release where they literally bawled their eyes out for 45 minutes. Which is just a reminder that a lot of these muscles, especially the ones that can't get touched on the surface, hold a lot of emotional energy. I'm going to go ahead and take this one out. Boom. And that is the needling for subscapularis. All right, so from this position in the heart 1, I'm going to go superior and medial and posterior. Then I can feel the scapula and I can feel that I'm on that muscle. I go up and in, holding that skin up next to the muscle and press the needle in nice and slow. And I just hit the scapula, so I know I'm on it. And that's it. So, for stretching the rotator cuff muscles, it's pretty easy. You just go the opposite direction of whatever the muscle does. But you need to stabilize. So if I rotate, because remember this rotates the humerus. If I rotate like that, look what happens with the scapula. When I go like this, look what happens with the scapula. You got to keep that stabilized. So your elbow goes right on the scapula. Your hand holds the elbow, and then you rotate and you hold down. One thing to be aware of is when you're rotating the hand towards you, you got to make sure you're not like actually putting it someplace that would be a violation of boundaries. And then up here, you rotate this direction. So that's going to get subscapularis, and then when your hand goes towards you, Teres minor and infraspinatus when you're going away from you. The only way really to get the the supraspinatus, would you sit up? Is, well, there's the eagle stretch, like eagle pose from yoga. But what I prefer, move forward a little bit, is, and this is pretty simple, just bring the arm behind them and pull, stabilize here and pull straight across. And that's going to stretch that supraspinatus out just a little bit. All right.